Hello, everyone, and thank you for joining me for another session at the CARE Conference Week. We will be talking about the neuropsychological assessment of the Hispanic patient, more specifically, psychometric limitations and cultural considerations. I want to extend my gratitude to Dr. Don Newman and all of the organizers for this conference that made this happen for us so that clinicians and researchers could be able to showcase the research that we're doing and really just talk about important topics that all of us feel passionate about. I also want to extend my many thanks and acknowledge the contribution and support that I always get from my co-author and colleague, Dr. Devan Parrott. And so for the next few minutes, we're going to be examining cultural variables implicated in neuropsychological assessment and their impact on cognitive scores. And we will also look to understand the cultural and psychometric drawbacks of commonly used tests in neuropsychology practice when evaluating the Hispanic patient. And this is going to make a lot more sense as we go through the data that we generated from this systematic lit review that looked more specifically at existing normative groups and just the many challenges and drawbacks that we found in those studies. Now, Hispanics in the US are now considered the largest minority. This is why you see me trying to work with Hispanics in any capacity that I can, both in terms of clinical and research efforts. The census from 2020, what that highlighted is truly just how much, or the US, just how much it continues to diversify with every decade. Specific to the Latino and Hispanic population, they are now, we have about 62.1%, 62.1 million of Hispanics living in the US as of 2020. And by 2050, we are expecting a projected growth to be about 111 million of Hispanics. By 2050, Hispanics will also represent about 29% of the total US population. But despite their growth and their ongoing expansion, what we see often is that Hispanics are significantly affected by healthcare disparities. They are at a greater risk of developing multiple neurological diseases ranging from dementia, traumatic brain injury, epilepsy, and stroke. And despite ongoing efforts and just greater acknowledgement that healthcare has to do better for Hispanic patients, what we oftentimes see is that Hispanics are not really getting equitable access to rehabilitation services that other majority groups are getting and are benefiting from. And so, of course, when you look at outcome measures, Hispanics do really poorly in comparison to other white non-Hispanic groups. Now, you guys may have seen these terms in the literature, Latinx and Hispanics, and oftentimes they are used interchangeably, but they are technically not the same. And any clinical neuropsychologist doing cross-cultural work is going to care about this distinction because for clinical and assessment purposes, it actually matters. So when you guys see the term Latinx, this refers to a person that is born in or ancestors or family are from Latin America. So Latin America is a really expansive, really large geographic region. It comprises countries such as Mexico, countries in South America, Central America, and the Caribbean islands, those being Cuba, Puerto Rico, and Dominican Republic. So when you see the term Latinx, this is referring to individuals that, again, their ancestors or family or they themselves are born in Latin America. So that automatically includes Brazilians despite speaking Portuguese and excludes Spaniards despite speaking Spanish because Spain happens to be a European country. Whereas individuals that you refer to as Hispanic, that now encompasses people only from Spanish-speaking countries. So at this point in time, you are including territories from Caribbean and Spain, despite Spaniards being considered technically an European country. As far as demographic and cultural variables known to impact neuropsychological performance, we seem to have a lot more robust and really well executed research looking at the contribution of age and gender. This is why now a lot of our normative data that has been based or normed on Caucasians, for example, they do stratify the data based off of age and education. And some normative studies have looked at gender differences, and therefore they account for gender as part of their analyses. Now, we have less foundational understanding as far as cultural variables, those being acculturation, bilingualism, language acquisition. So when was English acquired as a second language, and years of education, not only the total amount of education, but looking at the ratio of education that was acquired in the US versus their native country. So truly, we don't really seem to have a really good foundational understanding as to the effect of cultural variables that are implicated that could contribute to variance noticed in cognitive performance, whereas we seem to be a lot more comfortable and understand a bit more thoroughly the contribution of factors such as age and gender. For anyone that is doing cross-cultural work, specifically cultural assessments, the culturally responsive evaluation or culturally responsive clinician, and notice the word responsive. Responsive, I think, really speaks to this very active process of understanding that my knowledge, the one that I have right now, is only going to take me so far. With the more exposure that I have and the more evaluations that I conduct and the more knowledge that I acquire, it's important to recognize that with new knowledge, I do have to modify what I think I understand about every single culture that I'm coming across. And so it's a very culturally and very active process in sort of acknowledging what I know, recognizing what I don't know, and then once we come across new data, we incorporate that new data and we modify what we think we knew about this person and this culture. And so someone who is culturally responsive as a neuropsychology clinician, they're going to be considering the effect of several demographic variables, inclusive of degree of acculturation, the language fluency, whether it is primarily Spanish or English, degree of bilingualism, comfort level with the assessment. So more specific to testing considerations, the culturally responsive clinician is going to be considering language of administration really early on in the process of the cognitive assessment. You as a clinician are oftentimes considering from really early on, is this an evaluation that I have to do in Spanish, in English, or is this a bilingual assessment that I have to do, especially if you happen to be dealing with what the literature refers to as a balanced bilingual, someone that is able to speak, write, and read in both languages. And when you formally test their language proficiency, they happen to be pretty equivalent in both languages. So if you do encounter that kind of patient, the bilingual assessment is actually a better, it's a more appropriate adaptation and more of an appropriate assessment process rather than choosing one language or the other. More considerations that you're doing that are more specific to test selection, that is inclusive of the clinician having to think about what kinds of instruments do I have access to, what norms do I have at my disposal, considering my normative groups, right? So understanding that I have a very heterogeneous patient in front of me, and then going back to my normative data set and making sure that cultural characteristics are somewhat included or captured in this normative group that is similar to the patient that I have in front of me. And so if that's not the case, then I have to get creative with this assessment process. And then of course, the scoring. Neuropsychology is a science that is very data-driven. And so when you're dealing with someone that is a member of a group that tends to be less heterogeneous, the quantitative approach to scoring would be the best approach with that person. And so it's quite culturally appropriate. Whereas if you have someone that is more of, he or she is a member of a more heterogeneous group, at that point, you may want to consider that in addition to the quantitative, to have a qualitative component in your scoring process. And so the scoring section of the evaluation becomes more of a process type of approach that, again, is inclusive of both quantitative and qualitative information. And it would be very appropriate when dealing and evaluating the Hispanic patient. There are several drawbacks that move beyond the normative data set. We could see drawbacks that are task specific. So again, having measures that really are not or do not seem culturally relevant or culturally appropriate, having limited normative samples that are based on Spanish-speaking Hispanics, and then, of course, always having the concern that some normative groups just simply fail to account for important variables, such as education, other cultural variables, and we'll talk more about those. It could also be clinician specific. Some clinicians have not really received formal training on cross-cultural neuropsychology, and so with lack of training, understandably, there's a sense of discomfort with working and evaluating someone from a minoritized group. And then it could also be patient specific, especially when you have a language barrier, and that barrier, as most of us would think about the patient speaking Spanish and the evaluator only speaking English. You could be an evaluator that understands and speaks Spanish, but in a more informal way, especially if you consider that you could have a Hispanic patient that has only been in the US for maybe 5 or 6 years. Their entire schooling and academic years were acquired in a Latin American country, whereas you as an evaluator, your family is maybe from Mexico, you were born in the US, you grew up initially speaking Spanish in your household, but then your entire academic career has been taught in English. And so it's fair to say that professionally, your entire professional fluency and proficiency is in English, which automatically does create a different degree of communication between you as an evaluator and your patient. And so again, these are just factors that any individual doing cross-cultural neuropsychology has to keep in mind. Now, why normative studies are incredibly important in neuropsychology, it really goes back to the function of what these studies actually give back to any clinician. And so normative data sets really provide the context in neuropsychology. So a raw score of 5 or 12 or 25, they actually mean nothing if we don't have any sort of context that we can go back to and utilize, right, in this assessment process. And so having a raw score of 5 and also having access to a normative data set that we can compare that raw score to that normative group, it's actually going to let the clinician not only establish whether we have presence or absence of pathology, but it's going to let us be able to distinguish or even provide a classification as to severity of that pathology, right? So this is why it's really, really important that neuropsychology evaluations are based on this normative group that many studies do provide us, so that we are able to bring context into this evaluation process. And so we were interested, so I've given you a very brief overview of the many drawbacks and at which levels we could see these playing out in the assessment process. And so with this specific study or project, we wanted to look at the existing normative studies, and we wanted to look at the normative databases that have been validated and normed on Hispanic individuals, healthy Hispanics. And so we used keywords anywhere from neuropsychological assessment, cultural adaptation, acculturation, bilingualism, and we pulled articles from about 5 different databases. Our inclusion criteria was any peer-reviewed article published between 1990 and 2021. We included studies with specific psychometric properties of normative samples. We considered any study that included cultural proxies such as bilingualism in their analyses, and 28 studies met our inclusion criteria. Now, as far as what we found, the largest normative study validated on Hispanics, healthy Hispanics, was actually conducted in Latin America. And this is from the work of Dr. Juan Arango Lasprilla and his colleagues. This is a study that initiated back in 2015. Norms were actually not published until 2018, early 2019. And what they did was pretty remarkable. They took about 12 to 13 commonly used neuropsychological tests, and they normed all of these tests in about 12 different countries in Latin America. So their overall sample was close to 14,000 healthy Hispanics. And this was a massive undertaking. And so the major concern with this study, it's primarily theoretical, because again, we have no evidence in support or against these concerns. And that is for any clinical neuropsychologist in the US evaluating a Hispanic living in the US who is likely bilingual, likely acculturated. The concern goes back to the equivalence of the Hispanic that I'm trying to evaluate, and that Hispanic being equivalent to the Hispanics that you see in Latin America, who are not acculturated because they don't have to be, that maybe they do not speak a second language because they don't need to speak a second language, right? And so again, theoretically, there is concern with the equivalence of samples, right? The Hispanic that I'm trying to treat and evaluate, and how that Hispanic compares to Hispanics outside of the US. Other studies have been based on really small sample sizes. This is something that you see quite frequently, and it may not be something that you see right away, because you may have an initial sample size that looks okay, but then you stratify that initial sample size based off of age, for example, and then you start creating different age ranges. And what you see often is that after you stratify based off of age, you could have an age range with maybe 10, 11, or 12 individuals, Hispanic, healthy individuals, which is really not ideal for normative purposes. Anyone who's doing normative research would want to see at least, to a minimum, 50 individuals representing that initial or that age range, if not more, right? And so the issue with many of these studies is that they start really strongly with a very strong, very adequate sample size, but once they stratify that sample based off of different variables, you start seeing those ranges not showing less than ideal individuals per that age range. And so it really limits the generalizability, and it's really not ideal for normative purposes, especially when you're doing normative comparisons. Other studies that we found were either way too region specific or used very narrow Hispanic groups. You see this often in the West Coast region of the country. States like California, Arizona, all that entire West Coast, they're quite active as it relates to wanting to validate current instruments on Hispanics, but because the US border being so close in proximity with that region, what you find often is that their entire normative sample is actually of Mexican descent, or truly just individuals from Mexico that go back and forth between Mexico and the US, which again limits generalizability to other Hispanics that are quite heterogeneous groups. Other studies that we found, they used very small test batteries, and which of course is concerning when you remember that neuropsychological cognitive batteries tend to be quite time consuming. You're talking about anywhere from 5 to 6, 7 hours worth of testing. And so when you have studies that have only looked at validating the R bands, for example, that automatically poses a lot of concerns and issues for clinical neuropsychologists who are evaluating Hispanics. Other studies have based their normative grouping just based off of very restrictive age groups. You see this more often with midlife and older adults. And for most of us who are treating and evaluating someone, let's say with a traumatic brain injury, who happens to be in their 20s and 30s, automatically that limits the utility of a lot of these normative groups that are just way too restrictive in terms of age. And other normative studies that we found were conducted over 20 years ago, and similar to the concerns that we saw with Dr. Juan Arango Lasprilla's Latin America study, which I've already said, it's primarily theoretical. This is another theoretical concern that comes up with a study that has been conducted way too long ago. And this is when you consider that even within a family, you may see a lot of generational differences. And so it begs the question, is it possible that Hispanics that migrated 20, 30, 40 years ago, are they different than the more current wave of Hispanics that are migrating now more recently? And I think theoretically, I think there's valid concerns with this, and there could be some validity with that concern, which is why there's always the concern that some of these may just be obsolete, which is why we need to, for future normative studies, we need to make sure that we are tapping the more recent waves of immigrants. So overall, in terms of, if I could summarize this for you, we really did not find significant amount of studies that have controlled or accounted for cultural proxies in normative investigations. So truly, to this day, it is unknown the degree that cultural variables could moderate the neuropsychological performance. There's really not robust research. There really is no strong normative study that has looked at cultural variables in addition to demographics, such as bilingualism or acculturation, and looking at the specific contribution of those cultural variables in cognitive performance, which I think is an important limitation in the field of neuropsychology. So for final thoughts, I think it's important to consider or continue to appreciate the different challenges that I think are embedded in any profession in the healthcare field. But I don't think that appreciating those challenges is enough. I do think that we have to continue being proactive and consistently work towards improving the neuropsychological care of our patients. And so when I say that out loud, I think of two important avenues for improving or enhancing care for Hispanics. One, which I've already talked about extensively, and that is truly conducting more robust normative study research, looking at understanding, expanding our knowledge and foundational knowledge of moderating cultural variables and truly getting at the bottom of the contribution of cultural factors and how they could contribute to cognitive performance. Another thing that we could do, which I think many clinicians are already doing, or researchers, I should say, it's really looking with a critical lens at the existing instruments and really taking a closer look at the appropriateness of those instruments and really establishing how culturally appropriate are they? Are they culturally sensitive enough? And if that's not the case, then we have work to do. I think a paradigm shift may also be required when conducting research with Hispanics. We do need to start cultivating cultural humility in clinical research. We could be sort of bringing into clinical research techniques such as reflections, which is a technique that is used in qualitative research. And this is where the researcher explores personal beliefs in order to be more aware of potential judgments that are always being made in this dyad sort of interaction, reflecting on basic ethical principles such as autonomy, beneficence, and justice, We also have to be really cautious of cultural stereotypes and making assumptions along the way that are derived from notions of differences and explanations of the study findings. It's important to also recognize the existing power imbalance. We know that this is a very important attribute in a lot of clinical relationships. I do think that there's a power imbalance that is inherent in clinical relationships, but also in research. So we need to make sure that we are cognizant of that dynamic when working with research participants. And of course, we always want to consider the context and the history that every clinical patient and research participant is bringing with them. And of course, this is also that we, in this pyramid of cultural adaptation and cultural growth, we are moving from lower levels, which would be cultural destructiveness, cultural incapacity, and moving towards the upper levels, those being cultural competence and cultural proficiency, with, of course, cultural humility at the forefront of all of our efforts. And with that, I am going to end my presentation. And once again, I thank everyone for joining me today. And I look forward to seeing some of you present at the CARE Conference Week.